Pleasure to talk about a topic very near and dear to my heart, women's health and IBD. So, we'll be covering several aspects of this. So, we'll be talking a little bit about family planning, pregnancy, menstruation, menopause, as well as health maintenance as it relates to women's health. So, in terms of inflammatory bowel disease numbers by gender, so we know roughly over 3 million people here in the United States have inflammatory bowel disease. So, the ratio is close to 50-50 as it relates to men versus women. Women may have a slightly more increased prevalence of developing inflammatory bowel disease in their adult years, but overall, it's close to 50%. In terms of the age of onset of inflammatory bowel disease, the vast majority of patients who do get diagnosed with inflammatory bowel disease typically get diagnosed in their 20s and 30s. So, this is around the same time period where young women are thinking about contraception or family planning or pregnancy. So, certainly a very important time period in a woman's life. A small percentage of patients, probably around 15%, do present in their later years, somewhere after the age of 50, 55. So, in terms of contraception, so what are some things that my patients and I talk about? So, we talk about when is the best time to be thinking about getting pregnant, and certainly thinking about getting pregnant when you're flaring is not ideal. Potentially contraception should be used during this time. In terms of the different types of contraception that are recommended in patients with IBD, long acting non estrogen contraception modes are preferred. So these include things like an IUD or contraceptive implants. There has been some data of high dose estrogen being linked to clot formation. So, kind of thinking about our IBD patients who may have more moderate to severe inflammation, they may be at risk for clot formation as well, just from their active inflammatory bowel disease. So, we like to avoid high dose estrogen contraceptions in those patients. And overall, I would say the vast majority of obstetricians are probably not prescribing high dose estrogens. If anything, it's a low estrogen pill that's being used for contraception. Another thing to kind of keep in mind, I know we talk a little bit about absorption of medications. So it's important to consider that oral contraceptive pills may not be as effective, especially in somebody who has Crohn's disease that's extensive. The small bowel, we typically divide it into three parts: the duodenum, the jejunum, and ileum. So if a young woman has inflammatory bowel disease or Crohn's disease in multiple areas of the small intestine, they may not be able to absorb oral contraceptive pills as much. And the same thing could apply to somebody who's had extensive bowel surgery, again, in their small intestine. Those patients may not absorb oral contraceptive pills as well. So potentially an IUD or contraceptive implants may be more beneficial. In terms of deciding to have children, there's certain things that I think my patients who are women get concerned about. So one common thing that we talked about, well, what is the risk of me passing on inflammatory bowel disease to my children? So it's interesting that I think the vast majority of women tend to overestimate the risk of IBD in their children. So if we take a look at the risk of developing IBD and kids of mothers who have inflammatory bowel disease, the risk is fairly small. So Crohn's disease tends to be a little bit more genetic, so the risk is less than 5%. Ulcerative colitis, the risk is less than 5% if a child with a mom has inflammatory bowel disease. However, the risk may be higher. So if both parents have inflammatory bowel disease, the risk may be as high as above 20%. Um, Choice to remain childless is also tends to be higher in patients with inflammatory bowel disease. Some of this may be a personal choice, some of this may be due to misinformation. However, I think as we've made strides in patient care to provide preconception counseling, that has certainly helped increase the IBD patients' pregnancy rate by decreasing voluntary childlessness. So this survey that's in this table right here kind of alludes to some concerns about pregnancy that patients have. So one thing that patients get concerned about, well, can I become pregnant? What about medications? Could they potentially harm my baby? Would I potentially have more of a complicated pregnancy if I have inflammatory bowel disease? So these are all things that I talk to my female patients when they're contemplating pregnancy. So in terms of getting pregnant, when is the right time to think about getting pregnant? So it's the chance of getting pregnant compared to the general population, healthy population, is actually quite equal, and this tends to be more prevalent in somebody who has inflammatory bowel disease that's under good control. So that's what we term as remission. So these patients have a higher chance of having a good outcome in terms of getting pregnant and having successful pregnancy. Something that may have an effect on a woman's ability to get pregnant is if they've had pelvic surgeries. So J pouches, for example, may decrease fertility. However, certainly I think we've made advances in assisted reproduction technology like IVF. Interestingly, I would say that in somebody who's had a J pouch who isn't able to get pregnant after 6 months, we've had really great success with using IVS for those women to be able to get pregnant. And the chance of being able to get pregnant with using these type of assisted reproductive technologies, that's actually equivalent to the general healthy population. Women ask about, well, these medications that I'm on, am I able to get pregnant? Is it going to decrease my fertility? So no medications for pregnancy really decrease fertility as a woman. There are a couple of medications that can affect sperm quality, primarily in men. So these include sulfasalazine and methotrexate. So these medications, if a woman is trying to get pregnant and their significant other or husband is on sulfasalazine or methotrexate, we usually recommend holding those medications if possible for at least 3 to 6 months. So in terms of other things that we kind of talk about in clinic when it comes to preconception. So number one, as I mentioned, we want to make sure that the women's inflammatory bowel disease is under good control to be in remission. So what does remission mean? Number one, it means that the patient is feeling great, right? So we want them to be in clinical remission. We also want them to be off of steroids. So ideally, we want women to be off of steroids for at least 3 months and being able to show that she can stay in remission off of steroids before considering pregnant. Ways that we confirm remission, apart from just kind of talking to the patient and seeing how they're feeling, we're also kind of gathering data to make sure the patient is in remission. So this includes getting blood work, maybe even doing a colonoscopy. So I routinely will talk to my female patients with inflammatory bowel disease about doing a colonoscopy prior to getting pregnant, just to make sure what we're dealing with and to make sure that the IBD is in remission as well. The other thing that we kind of talk about is healthcare maintenance, making sure that their healthcare maintenance is up to date to having a successful pregnancy. So making sure they're up to date on their PAPs, up to date on their vaccines. Certainly, a woman who's trying to get pregnant should not be using drugs, drinking alcohol, or smoking. Um, Opioids also can have an effect on pregnancy outcomes. So if somebody's taking narcotics for any reason, they should be able to taper off prior to getting pregnant. We also make sure they're up to date on their colon cancer surveillance, make sure they're at a healthy weight. So somebody who has active disease, maybe they may be underweight. So we want to make sure that they're at a healthy weight. Of course, starting a prenatal vitamin, and then certainly if somebody's not thinking about getting pregnant, making sure that they're on effective contraception. In terms of fertility issues, again, like I mentioned before, there is a decreased fertility with certain pelvic surgeries. Active IBD as well can decrease fertility rates. So inflammation can have an effect on menstruation and can have an effect on a normal cycle. So it's really important again to make sure that the woman is in remission. For women who want to try getting pregnant on their own with J pouches, I think it's certainly reasonable. For whatever reason they're not able to get pregnant on their own after 6 months, we'll refer them to our reproductive endocrinologist for further evaluation. In terms of medications, so most of the medications that we use for management of inflammatory bowel disease that a female patient may be taking are fairly safe in pregnancy. However, there are certain medications that may not be. So methotrexate is one that we typically avoid because that can have an effect on fetal development. So it's what we term as a teratogenic medication. So a woman should be off of the medication for at least 3 to 6 months. If someone is taking sulfasalazine, which is not a common medication that we tend to prescribe, that can have an effect on absorption of folic acid. So we want to make sure they're taking folic acid along with that medication. Again, ideally, I love for my patient to be off of steroids before thinking about conceiving. So we want to make sure they're tapered off of steroids. They can continue azathioprine, 6-mercaptopurine. They can continue their biologic agents. There's this newer generation of molecules that we talked about earlier this morning, what we term oral small molecules. So these include medications like tofacitinib or Xeljanz or Zelnorm, Rinvoq. These are all oral small molecules. Given that they're the newer agents on the block, we don't really have as much data on outcomes in pregnancy. So if there are other medications that we could potentially use for management of IBD, that may be preferred rather than using these medications. But certainly there are certain online registries that are currently ongoing to help with gathering data on women who may have gotten pregnant on these oral small molecules. So time will tell how we'll use them in our women who are thinking about getting pregnant. So again, when is the best time to get pregnant? I can't stress enough making sure your disease is under control, as evidenced by being in remission, being on stable medication doses, and off of prednisone. Now, how do I ensure that that my pregnancy, once I get pregnant, will have the best outcomes? Stay on your IBD medication. Sometimes, women will come to me that I've been seeing for a long time. They get pregnant and they decide that they're going to stop their injectable medication, their oral medication. So it's really important that women, if they're concerned about their medications and they're pregnant, to talk to their GI provider about it, because we know that flares can increase the risk of miscarriages. They can have an effect on preterm delivery, low birth weight, and there's a lot of research that has kind of come out that how inflammation can have a negative effect on cognitive development of the baby. So another important reason why we should be taking our medications. If for whatever reason you start flaring when you're pregnant, notify your GI doctor immediately. I mentioned that steroids we like to avoid, pre-pregnancy, but sometimes we do have to use these medications to get the disease under control. So it's really important to notify your GI provider if you start having flare symptoms. Again, stopping all illicits, alcohol, tobacco use, and tapering off of opioids is really important. Are medications safe in pregnancy? Again, most of these are safe. We talked about how we need to avoid certain medications like methotrexate. Sometimes we use antibiotics primarily in patients who have Crohn's disease. Maybe they have fistulas. So you may have heard of ciprofloxacin or metronidazole, flagyl. We like to avoid these, especially in the first trimester in our pregnant women. Another important thing to note is that if you are on immunosuppressives when you do get pregnant, is to avoid live vaccines for 6 months for the baby after the delivery. The only live vaccine that a baby gets during that first 6 months is the rotavirus vaccine. So, anytime I have a brand new mom who has inflammatory bowel disease that comes to my office, I'll usually see her sometime during her third trimester, and I tell her, you know what, you need to go ahead and meet with the pediatrician even before you have the baby. Just do a meet and greet, talk about your history, talk about your husband's history, and then talk about this rotavirus vaccine. And especially since you're taking a biologic agent, it's probably not a good idea for the baby to get that particular vaccine the first 6 months. Now, how about after pregnancy? So in terms of mode of delivery and how that can affect how you take your medication. So, for the vast majority of our patients, women who are on biologic agents can immediately resume their agent after delivery. So, vaginal delivery, we say within 24 hours. If you have had surgery with a C section, as long as there's no infection, one can resume it within 48 hours. In terms of things that we talk about after delivery or postpartum, lactation, breastfeeding. So the vast majority of medications, again, are safe with breastfeeding. There are certain medications that we like to avoid the women to be breastfeeding when they're taking these medicines. So this includes methotrexate as well as the oral small molecules, again, since we don't have as much data. But other medications like thiopurines, biologic agents can be continued during breastfeeding. Again, making sure vaccines are up to date. In terms of developmental milestones, the data from some of our registries in looking at women who have had babies being on these type of immunosuppressive medications, babies have met their milestones. So these medications, again, really are beneficial to the mom in terms of keeping her healthy, but really don't have much of a negative effect on the baby. Other things to kind of think about is, let's say that I have a pregnant mom who has a stoma. So sometimes with the stomach getting a little bit bigger, sometimes there may be an issue with stomal displacement or stomal problems. So this is when I involve my surgeons, my IBD surgeons, to help me out with that. So kind of getting out of pregnancy and all that, just a little bit about menstruation. You know, Menses can actually be a sign of health. So, in some of my young women who have active disease, we do notice that the onset of puberty is delayed and menstruation is delayed in some of these younger women who get diagnosed with inflammatory bowel disease. Again, having a regular period can be an important indicator of health. So, it's not uncommon in some of my women who've had normal cycles for an extended period of time, and now suddenly their disease is is not under good control, that they may miss a cycle or may have a regular cycle. So it's really important to kind of keep an eye on one's menstrual cycle, especially if they're dealing with active inflammatory bowel disease. Women come to me and say, you know what, sometimes I have, really bad abdominal pain or cramping. It's, seems like I have IBD activity, but then it just goes away. I'm like, oh, this is happening during your cycle. It's a very common manifestation for women with IBD to experience menstrual pain or potentially regular periods as well. IBD symptoms such as diarrhea and abdominal pain, again, may be more severe before and during menstruation. An important thing to note, especially in a woman who may be taking steroids, this may lead to more irregular cycles. So that's something to kind of consider as well. When to notify your doctor about menstrual cycle. So if one's periods haven't started by age 15, if they're getting closer together than every 21 days, if they're getting further apart, if they're 90 days or more between periods, even just one time, if the periods are heavy, if the periods last more than 7 days, those are all indications to notify your physician. Menopause and IBD, there's really not a whole lot of research or literature on this, but overall, most women who are going through menopause who have inflammatory bowel disease really don't note that their IBD symptoms change much. In terms of when menopause starts relative to the general population, the data is somewhat mixed. One study seemed to suggest that women with IBD may have menopause a little bit earlier. Another study really found no difference in the age of onset. In terms of other questions that sometimes my female patients ask about, like hot flashes and things like that, will that get worse around menopause since I have IBD? And typically, for the vast majority of patients, that's not really affected by their IBD activity in terms of menopause and vasomotor or hot flash symptoms. An important thing to consider when a woman enters menopause is to think about bone density scans. It's something that not a lot of women consider as a potential health maintenance thing. But we do know that patients with inflammatory bowel disease are at increased risk of osteoporosis. So this could be related to steroid use. This could be related to malnutrition, having low vitamin D, low calcium. Active inflammation can also have a negative effect on bone regeneration as well. So just having IBD may increase the risk of osteoporosis. And then you throw on top of it being postmenopausal, that can also increase the risk of osteoporosis. So it's really important to get a bone density scan when you hit menopause. In terms of health maintenance, vaccines, we talked about that a little bit earlier with Dr. Prasad. So she went over the new guidelines for the HPV vaccine. She talked about COVID vaccine. Certainly we want to encourage flu vaccines, pneumonia vaccines, vaccines against shingles as well as tetanus. In terms of cancer screening, the American College of Gynecology recommends pap smears in the healthy young adult every 2 to 3 years. However, women that are immunosuppressed may be at higher risk of what we term cervical dysplasia or precancerous changes of the cervix. So one may consider getting annual pap smears in somebody with IBD who's on immunosuppression. In terms of mammograms, IBD or any of the medications that we normally prescribe for management of IBD really doesn't increase the risk of breast cancer. So it's really important just to follow the advice of the primary care physician on getting your routine mammograms. Skin cancer, there is a slightly increased risk of skin cancer just from having IBD. Certainly, certain medications may also increase the risk of skin cancer. Some of the oral small molecules, medications like azathioprine, 6-mercaptopurine can increase the risk of non-melanomatous skin cancers. Some of the anti-TNF agents, I'll use brand names because it makes it easier. So, like Humira, Remicade, and Cimzia, those can increase the risk of melanoma. So, it's really important to see a dermatologist on a regular basis. Colon cancer screening and our IBD patients that have colonic disease. So if you've got Crohn's colitis or ulcerative colitis, you may be at increased risk of colon cancer. So it's really important to stay up to date on that. We talked about bone density scan as well already. Another thing that we recommend, probably more so in patients on steroids or chronic steroids, because that can increase the risk of glaucoma and cataracts and such. And so we usually recommend seeing an ophthalmologist on a regular basis if somebody keeps getting steroids on a routine basis. But we like to avoid that. But sometimes, unfortunately, patients can avoid that. So with that, that's it for me. So I'll take questions at the end.